Hello, and welcome to the Center for Health Design's Evidence-Based Design Journal Club. Thanks for joining us. My name is Alan Card. I'm a research associate with the Center for Health Design, and I'll be your host for today. Before we begin, I'd like to thank the Health Environment's Research and Design Journal for providing free access to the articles we typically review. If you've not already done so, we recommend subscribing to HERD. There's a discount code for attendees to receive 20% off the subscription using the code HERD20, that's HERD20. The purpose of the Evidence-Based Design Journal Club is to engage the healthcare design community in dialogue regarding important research to help us better understand the links between the built environment and health-related outcomes and to apply that in the real world. EDAC, continuing education units are available for this webinar from the AIA and from EDAC. To receive credit for your participation, you can download the forms at any time by clicking on the Show My Media Library icon, which is located in the top right toolbar, where the red arrow is pointing. You'll have access to the AIA quiz, the EDAC form, and today's presentation slides. To download a file, click on the green arrow next to the file. When you're finished, click on the double right arrow at the top left corner of the media library. The library will close and the slides will refill the empty space. For EDAC credit, complete the verification form and retain it for your records. You'll need to submit the form to Castle Worldwide at the time of your renewal. For AIA credit, complete the verification quiz, purchase a CEU management fee for $10 from CHD's store, and submit the verification form to Catherine Anchetta. She'll upload the credits to your AIA account. You'll find Catherine's email address included on the form. I'd like to take a moment to review how to use the chat feature so you can ask questions or submit comments on what you hear today. As shown on this slide, just type into the chat box where the red arrow is pointing. Please be sure to chat your questions to all so that all attendees on today's call are able to see your message. If, on the other hand, you're having any technical difficulties, please type your issue to moderator in a private conversation, and we'll see how we can help. I'd now like to introduce you to the author of the article we're going to be discussing today, Dr. Anjali Joseph. As the Spartanburg Regional Health System's Endowed Chair in Architecture and Health Design and Director of the Center for Health Facilities Design and Testing at Clemson University, Dr. Anjali Joseph is focused on using simulation and prototyping methods to research and test effectiveness of promising design solutions that may impact patient safety in high-stress healthcare environments. She has focused her research on multidisciplinary approaches to improving the patient safety in healthcare through the development of tools and built environment solutions. She is currently leading a multidisciplinary ARC-funded project to develop a learning lab focused on improving patient safety in the operating room. She led the research activities at the Center for Health Design before joining Clemson. Here she served as principal investigator on several grants from different organizations such as the Robert Wood Johnson Foundation, the Agency for Healthcare Research and Quality, U.S. Green Building Council, and the Kresge Foundation. Anjali's work has been published in many academic journals and magazines. She frequently peer-reviews articles for journals. Anjali obtained her PhD with a focus on architecture, culture, and behavior from the Georgia Institute of Technology, master's degree in architecture from Kansas State University, and bachelor's degree in architecture from the School of Planning and Architecture in New Delhi, India. Thanks very much for joining us today.
Well, thank you, Alan, for the introduction. I have to say, this is the first time anyone, I think, read the whole introduction out. But nice to meet everybody on the call, all of the fellow researchers and healthcare design professionals out there. While I'm presenting this paper today, I have to acknowledge all the other wonderful people who contributed to this paper. Dr. Sarah Baramzadeh was she's the main author on this paper and a partner in crime for a lot of the work we've done. She now is at Kent State University, and there's also a great group of other clinicians, Dee, Amin, Kevin, Roxana, David Nyan, and this larger study group, which is almost 20 people that have been involved in this project in some form or the other. So I'd like to acknowledge all their contributions. And thank you to the Center for Health Design for inviting me to be on this call today. I'm looking forward to the discussion and questions from all of you. So as you all know, the topic of the presentation today is the impact of operating room layout on circulating nurses' work patterns and floor disruption, behavior mapping study. So if this is not the presentation you were hoping for, this is the right presentation. But again, I have feel free to ask questions. Alan, if you want to interject and ask, that would be great. And if others have questions, I'm happy to entertain them. Would love for this to be a conversation rather than me talking. But again, just to start off, why are we looking at the operating room? As Alan mentioned, this is part of a larger learning lab, and we're looking at various aspects of the operating room, and this is just one piece of it that we're presenting. But we decided to look at the OR because the OR is a very complex and risk-prone area. There are a lot of problems with surgical site infections, errors, and just staff ergonomics and health in the operating room. There's a very rare OR in the US that has daylight. I can't imagine working in an office that doesn't have a daylight. So there are a lot of issues in the OR that need to be addressed. And the OR, usually its boundaries are fixed, but you keep bringing in more and more technology, different kind of personnel in the OR without really much thought to how is it all working together and how is that going to impact outcomes. So what we were trying to do with this particular project is to have a systems approach to OR design that looks not only at the built environment, but also the technology, the equipment, and the people in the OR. So just to give a very quick context for this particular project, what I'm presenting today is an outcome of some of the work we did in the first year of this 4-year grant. We are currently in the fourth year of this project, started on September 1st. It's funded by HRQ. It is a Center for grant to develop a patient safety learning lab. And as Alan mentioned, our focus is to design a safer and more ergonomic operating room using a systems approach. It is a multidisciplinary approach, so all the people you saw on that long list of authors, they represent nursing, industrial engineering, anesthesiology, architecture, because we felt this was a problem that needed input from all these different disciplines. It's not something that any one of us can tackle effectively. It has 3 different components to it, which all fits into the main focus, which is designing this operating room. Our focus was in ambulatory surgery, given that very little research has been done on that. And also NUSC, that is the co-partner with Clemson on this project, is building a new surgery center. So we wanted this work to to develop a prototype that would inform the industry as a whole, but also specifically the new surgery center that NUSC is building. And of course, it's a university, and so we really focused on integrating the research and the teaching with industry partners who can help us make sure this is relevant, much broader than NUSC or Clemson. In this particular study, we are looking at the circulating nurse, and in the operating room, there are 4 key kind of participants: the circulating nurse, the scrub nurse, the anesthesiologist, and the surgeon. And then there's one or more of these different people. So usually there's just one circulating nurse, and he or she plays a very critical role in the OR, keeping track of what's happening in the OR, maintaining and managing the safety of the operating room during different phases of the OR, making sure everyone has what they need, and kind of managing the flow of information and supplies and equipment as needed. And they also have a very key role in linking what's happening within the OR with what's happening outside the OR, and also what's happening within the sterile part of the OR around the surgical table with the non-sterile team. Because the surgeon and the scrub nurse are scrubbed in and they're sterile and they cannot move. And there are a lot of problems with disruptions and interruptions during surgery that impact safety. And what we've seen and what we know through some of the research is that layout and adjacencies impact the workflow of the OR. So there are 2 main things that we were hoping to study with this particular project was to understand how the layout and adjacencies within the OR impact movement patterns for the circulating nurse, and to understand how these layout configurations impact disruptions to the workflow. So they're kind of interrelated things that we were looking at. I'm going to walk through the method really quickly because I'm assuming you've all read the paper, and you can ask me more questions as we go along. But really quickly, we looked at 2 different, we looked at hospitals, inpatient ORs at NUSC. 2 of the ORs were in an older building, and operating room A is a slightly larger OR built in a new facility at NUSC. And these are the size, these are the general layout of the 3 ORs, and they all have a sterile core and a non-sterile corridor. So that's one of the things that's common to all 3 ORs. They're different in size. And I'll talk a little bit more about all these colorful zones and things that you see over here. So what we ended up doing was video recording all the surgery. So prior to video recording, we went in and did some in-person observations to make sure we understood the context really well. And then we had these 4 video cameras in 4 corners of the OR that were all linked to one computer, and through which we could hit record, and when the patient entered, when the patient left, the recording ended. And we recorded 35 surgeries. For this particular study, we analyzed 25 of these that were most relevant. So once we had the videos recorded, we were able to use the noisist media recorder to then analyze the behavior. And, this is a behavior mapping study, so we really wanted to know what are the kind of things people are doing and where they're doing it, and what are the challenges that occur as a result of that for this larger study, because the whole idea was to do a ground-up approach to figure out what's happening in the OR, what are the challenges, how can we design a better solution for that. And so we came up with this coding protocol based on the literature reviews and so on. We did a lot of testing, and I can talk about that more later if you wish, to make sure that all the people who were coding had the same level of understanding about what needed to be done. And then what did we actually code? And that's a big question. So we wanted to code all the key people in the OR that are there throughout the surgery. So since this is an academic medical center, usually you would have 7 to 8 people in the OR at any time. So we kind of distributed it among the team members, where different people coded different team members. So if I was coding the circulating nurse, I would mark for any point in time where they were, so which of these colored zones they were in, and what they were doing. So these are the different people, and the zones that you see, typically each OR was organized into these zones based on the function that takes place. So this would be the anesthesiology zone, that would be the circulating nurse's workstation. This is the table in the middle with the 3 surgical zones around it, the foot of the table and the 2 sides. And then these gray areas were the supply zones, actually the support zones, and these green areas were supply zones in the OR, where supplies were typically kept. And what's around it is all circulation zones, which we call transitional areas. For the purpose of coding, this transitional area was kind of divided into 3 separate zones, so that we could mark approximately where the person was. And these are the kind of activities, very broadly classified, that we tracked throughout the time. So if we track somebody as being in the anesthesiology zone, doing a material-related activity or an information-related activity, or if they were doing something with equipment, or they were interacting with the patient. So those were the 4 PEM3 activities that were classified. And then the other thing we also measured was surgical flow disruptions. As I mentioned, our goals are to look at the workflow and then look at disruptions in the OR. So we modified an existing taxonomy called Ripcord that was actually developed by several people who are part of our research team, including Dr. Cottrey, David Allison, and so on. So we used that taxonomy and modified it a little bit. And these are the different kinds of categories of disruptions that we looked at: usability, layout, environmental hazard, equipment failures, and interruptions. For this particular presentation, we focused primarily on the layout and the environmental hazards, because that was the most environmentally focused of the disruptions we looked at. Alan, any questions from you or anyone else at this point?
So far, so good. Thanks.
Okay. I know someone mentioned that they were having problem with echo. Hopefully that's resolved now. Okay. So in terms of analysis, as I mentioned, we used noisist media recorder, and then we used Observer XT12 to analyze the data, and then we converted that into time-based data, so that for every second we knew exactly where everybody was and what they were doing, and also the surgical flow disruption data was organized by time. And so we did a lot of different analysis. So this paper is primarily descriptive analysis that shows the frequencies and duration of different kinds of activities. But then we also took this data and put it into a simulation software called AnyLogic, which creates a playback of the surgery, but on a plan. So we can actually see the spaghetti diagrams that you've seen in the plan. And we use bubble maps to visualize the frequency between those. So very quickly, what some of the findings are, so that we have ample time for discussion. Some of the key things we found was that the circulating nurse travels through a lot of zones. Most of the activities, even though most of her activities are information related and often at the circulating nurse workstation, about 92% of the activities did require traveling through multiple zones, even if they were information related. So they're moving from more than one zone to get to do what they need to do. And about the remaining were in the same zone. And this table kind of shows you where and what are the kind of activities that are happening in different kinds of zones. And I think that's useful for us to know what are they doing where in different places. For example, the circulating nurse workstation, most of the activities are related to information, that is with the computer or managing some sort of information on the phone and so on. At the foot of the surgery table, head of the bed, the activities often related to materials and supplies and equipment because they were often interacting with the scrub nurse, as you can see. And then the support zone was all about instruments and supplies. So this is kind of helpful to see where are they going to do what they need to do.
And one quick question about that, if you could go back to that slide. What is the difference between materials, instruments, and supplies and equipment? Where do you draw the line between those two?
So equipment would be like a C-arm or an anesthesia machine or like an actual big piece of machine, which will be in these ORs, they were mostly mobile pieces of equipment. And material instruments and supplies would be actually, like a suture or an instrument that the scrub nurse was handing over to the surgeon and so on. So they would be much smaller, and they would be either, instruments that were coming in from the FPD, or they could be disposable materials and supplies. That makes sense. Yeah?
Cool. Thank you.
Okay. So the other analysis we did, and all of these were to try and understand the work pattern and the workflow, understanding that a lot of the travel within the OR originates from the circulating nurse workstation. We did an analysis to see where are they going, and sort of when they get to the next destination, where are they going from there, and what's the most common destination that they're going to. So this process helped us figure out, which became also clear for some of the other things, that where they're going most frequently is the surgical table, the foot of the surgical table, or the sides of the surgical table to communicate with the scrub nurse, and they're also going quite a bit to the supply zone. And this was uniform pretty much across the 3 ORs that we looked at, across the different surgeries. So one of the key things, I guess, to take away from this part of the analysis is that most common travel path was from the circulating nurse workstation to the OR table or to the storage areas. And you can see in these 3 ORs that, there's varying amount of space and access to the surgical table from the workstation, and the supply zones in all of these ORs really was not very ideally located. I mean, they required them going by the side. This is usually where the scrub nurse would be, and you'd have to kind of go past that to get to supplies, which is not ideal. Then looking at the surgical floor disruptions, as we mentioned, there are 2 kinds that we looked at. So in these 25 surgeries, there were about 584 SFDs, out of which about 1/3 were environmental hazard and the rest were layout related. And this shows you sort of the location of these hazards, and if you kind of visually correlated to the movement patterns of the circulating nurse in these surgeries. So these are the 3 different ORs, and the blue lines are the extinct environmental, the layout-related hazards, and the orange are the environmental. And the size of the circle shows you the number of events that took place in these ORs. And you can see the layout and the movement patterns. So the location of those events happening sort of are parallel to where people were moving around the most. And in some of the ORs, the space is so limited that, it's kind of easy to see where that is happening. So in summary, some of our key findings that I think are relevant to talk about is that most of the CN activities require traveling through multiple zones, especially when it's related to retrieving materials. And traveling through all these multiple zones is not ideal in the constricted space you have in the OR. So if you make these zones that you need to go to relatively close to each other in terms of adjacencies, it would help in reducing the travel. The workstation is the hub for the circulating nurse with frequent trips to the supply zone and areas around the surgical table. And we saw a lot of high frequency of the flow disruptions in the transitional zones as compared to the other zones. The small size of the transitional zone in the OR, along with the high frequency of the travel route, contributed to the SFDs. And we noticed a similar work pattern across different surgeries. So what does it mean? I think some of the implications are pretty clear to us because we were going to take this information and then kind of translate that into the design of a prototype OR. So some of these design implications are important to us. So direct adjacencies were important based on our study between the circulating nurse workstation and the supply zone. The circulating nurse workstation needs to maintain a distance from the OR table to protect the sterility of the area around the OR bed. Because that's also an area where other equipment that is used during the surgery that may be brought in, like a C-arm or other kinds of things that may be needed, may be brought in during the surgery, and it all tends to accumulate around the OR bed. So there's an important criteria to have enough space there. The size of the transitional zone should be large enough to prevent crowding and disruption. And the location and mobility of the workstation may be a useful thing to consider. So one of our takeaways was that maybe we need to consider a mobile workstation that allows the CN to move the thing around to be close to the bed when needed, and then move away when you don't need to. But at the same time, they are not moving around so much in the OR. They can move the table and stay stationary and do what they need to do.
Anjali, I'm sorry to interrupt. We're getting some questions of whether you could try picking up the phone. Apparently the audio quality isn't coming across as well as it was in our little pretest. Right. Sorry.
Okay. Is this better? I brought it a little closer to me.
It sounds better to me. It didn't sound that bad to me over here. Much better, I'm hearing. So,
much better.
Thank you.
Okay. Well, you see me holding my pink phone now. That's okay. All right. So I'll just keep it like that. So just very quickly, with some of the limitations, it's a relatively small sample of surgeries. And when you look at all the different kinds of surgeries observed, that's an thing that you need to think about. This was data collected as a single health system. So to say that this is exactly the same as what other other ORs and other health systems do. But I think we've presented it at various venues and with different partners, and no one has said that this is kind of different in terms of the behavior patterns. And then the descriptive and graphical analysis help us to understand the pattern of findings, but we are not saying predictive causation or correlation as a result of this particular study. So we have conducted other studies where we've done regression and so on, and I have a list of all of those studies on the last slide that I would recommend the participants can go in and take a look at some of those if they want to get deeper into this information. So some of the future work that we're doing is to evaluate the proximities. We did the proximities for the circulating nurse, but perhaps look at it for some other team members like the anesthesiologist, because we have this large database, we could do stuff with it. Examine the zone, and then consider the interaction with other surgical team members. Here we looked at it almost in isolation for the circulating nurse, but we should be looking at other people too in this OR. And in case you're wondering, what did we do with all this? Where are we going with this? It was not a purely academic exercise, though it's been great to have this wonderful database that all our students and faculty can dig into. But we use that as the basis for the design process, where we spent about a year going through an iterative design process to come up with this human-centered OR design. And this is what the final prototype looks like. It has a lot of different characteristics, but the most relevant, I think, to this particular paper here is the focus on optimizing movement and flow. So some of the things we came up with was having this mobile workstation in this corner of the OR that can get closer or further away, having well-defined zones in the OR, so that whether it's a right-sided or a left-sided surgery, we'd have ample space for the scrub nurse and for everything else. The angle table, again, to allow enough circulation around the surgical table. The anesthesia zone is very well-defined, and in that corner, with their storage right next to them, we recommended, as you saw, in the earlier case, the supplies were all over the place. So here the supply zone is right next to the circulating nurse workstation, so they're not impeding on each other's zones, and the movement in and out is as streamlined as can possibly be made. So those are some of the implications from the study that we were then able to implement in this prototype. And we went through various rounds of testing of the prototype with clinicians. We did a lot of scenario-based simulations. And the final version of this is this high-fidelity prototype that is built in the Clemson Design Center, that is Clemson's sort of remote campus in Charleston, where we have this high-fidelity OR built with the booms and all the other equipment. And, we were supposed to be there next week to do a full surgical simulation with our complete surgical team. But thanks to Hurricane Florence, we're going to have to schedule that for another time. So maybe at a later time I can tell you how that works. But yeah, we're hoping our surgical partners and friends out there are all good. And yeah, so that's kind of where we are with this project. And I look forward to hearing your questions.
Thank you so much for that. Just writing down one of the questions there for you. Thank you, Anjali. Before we get to the Q&A session, I'd like to thank the Herd Journal again for which this study was published. Also, if you were attending the Healthcare Design Expo and Conference in November, be sure to check out education section E52, The Science of Healthcare Design, a review of studies published in the Herd Journal. This session provides an information-rich retrospective review of the studies published in the Herd Journal for the past 10 years. Participants will expand their knowledge about the state of the science in healthcare design. The science has been emerging over the last decade, and currently there are enough studies published to develop systematic literature review to guide healthcare design decision-making and the development of design guidelines. The Center for Health Design is conducting a behavioral health workshop on September 27th in Baltimore. You can learn more about the faculty and agenda on the center's website under events. And now, it's your turn to ask questions of the author. Please feel free to type in any questions you may have, and we'll try to answer them. The first one that I got was, how big were these ORs in terms of square feet? Since obviously that does play a role in flow.
Oh, yeah, no, absolutely. And I think that's an excellent question. Let's see. I'm trying to go back to the slide that I don't remember them off the top of my head. I'm going to go back to this thing, which I think has the sizes. So as I mentioned, the newer OR that was in the Art Hospital was much larger. It was 690 square feet. So this is an inpatient OR primarily, not outpatient. And then operating room B and C were much smaller at 390 square feet and 463 square feet. But, you know, as you can see, these are sort of almost at the limit of the FGI guidelines recommended minimum of 400 square feet for inpatient surgeries. And so it really is at that. But if you see all the equipment and stuff that they bring in, 400 square feet is not enough when you see all the equipment and the reality of how surgery is done. So, yeah. So we do think size makes a difference, but also the layout and the configuration. Like in all of these ORs, for some reason, the circulating nurse storage supplies are right in this corner behind the anesthesiology zone. That means that the nurse is typically coming all the way back here to get supplies, and that's not the ideal configuration. So even if you have a small OR, you can still lay it out more effectively. But we have the same issue over here. So someone, at MUSC came up with this design, and it's replicated. So the challenges were also replicated, I think, in all the ORs.
And that leads really well into another question. Somebody asked, they said the room design, the room size, I assume in the new prototype that you've developed, is larger than often planned for ambulatory surgery centers and above code minimums. Do you think the OR size at ambulatory centers should be this size?
Well, I think we came up with this size based on our simulations of the different scenarios with our surgical teams. So we ran through different surgeries and tried all, sort of critical situations, typical scenarios, and this seemed to be the size that seemed to work well, which wouldn't result in any kind of challenges. What we've done since then is actually use some of this workflow analysis that we've done with the in-depth coding. We've created a playback and a Markov chain simulation, which we've actually used to then test this 579 square foot prototype to see, is this the appropriate size? We've analyzed 3 different sizes of ORs and to see where the number of intrusions into the sterile zone, number of contacts between people, does that change as the size changes? And what we found is that as the size increases, some of these variables related to number of intrusions into the sterile zone, number of contacts, that reduces. But after a point, there's sort of diminishing returns. But we saw a big jump from the 400 square foot FGI recommended minimum to the 570. There was a big jump into sort of improvement. And then from the 579 to the 710 or something that we tested, There was an improvement still, but it was not as much it was not an exponential jump. So I think there's diminishing returns after a certain point for different kinds of surgeries. We just tested pediatric outpatient surgeries. So I think, we need to test proactively how it's going to be. So I can't say that this is the perfect one, but I do think the 400 square foot is really too little, especially for inpatient surgeries. That's the minimum. And I think for outpatient, the guidelines say 200 and something, which is, I can't even imagine how they would do the work that, based on all the observations we've done in these ORs. There's so much stuff that's in there and so much more that they bring into them that, really have to think about the workflow. It's just not about putting bunches of stuff in there. It's people that are going to be in there and all these disruptions that happen all the time. So it's worth thinking about minimums a little bit more carefully.
Got a couple of questions related to the idea of sterile core. Are you planning to study sterile core versus substerile layout conditions in addition to the work inside of ORs? And then another question saying the prototype OR seems not to lend itself to being organized around sterile core, and is this a consideration in the design?
Let me see if I can remember all those questions. And actually, okay, so I didn't talk enough about the prototype because that was not the focus of this paper, but what we tried to do with this prototype was to actually build it as a universal chassis that would work in many different kind of configurations. So actually, we designed it in a way that this would work without a sterile core or with a sterile core. So if you had a situation where you wanted to have a corridor and a sterile core, this location where you have the windows would actually be where we would have the door. And so you would have the circulating nurse workstation. I think maybe it's a similar thing, but you'd have the entrance you'd have another door over here that would allow you to have both. The idea was that this chassis would work whether you had just a single door, a sterile core and a regular corridor, a dirty core or whatever, dirty corridor, or if you decided to have ancillary rooms. Like in this case, we have an induction room. We designed it so that if you had an induction room, you could use it. If you decided you wanted a breakdown or decontamination room or something, you could use it. If you decided that down the road this thing needed to be moved into a control room because we were seeing an influx of robotic surgeries into the outpatient arena, that's possible. So we were trying to design it for the future, given that one of the first questions when we started the project was like, are you designing for now or are you designing for the future? So we had to keep kind of going back and forth with that this prototype should ideally be able to work in different kind of configuration, sort of, even for future conditions, how do you make it possible? So we have other features as well. Like, we have modular wall system that would allow this to be modified without significant changes to the structure. So, there's lots of other things that we haven't talked about in a lot of detail, but you'll see that when you look at your slides later.
Going back to a more basic question, you differentiated between environmental hazards and layout-related hazards. Could you talk a little bit more about what the difference is between the two?
Yeah. Okay, let's see. Maybe go back to that. The layout hazards were more things like not having enough space to get to things. Yeah, so the layout hazards were things like, not being able to reach things, there are connectors or wires that you have that you're unable to get to, or you have to squeeze through, or maybe because something is blocked, you have to kind of go around it to reach something else in the OR. So these are all sort of layout-related hazards, and environmental hazards were more related to slipping and tripping, bumping into things, interacting with objects or contaminated needles, collisions between people. That was more hazards. Does that make sense?
Sure. Now, you coded the team behavior using video as opposed to in-person observations. I can see some of given the small space constraints that you're dealing with, I can see some of the obvious advantages to that. Were there other advantages or disadvantages to that approach that are worth considering for people who are thinking about taking a similar approach?
Sure. I think there are pros and cons to both approach. With the video coding, obviously, as you can see, we were able to get an immense amount of very detailed, fine-grained data by analyzing it after the fact. To even code, one SFD, we probably had to rewind the video like 10 times to really make sure we were getting the right thing and marking it correctly, because it moves so quickly that it's almost hard to catch everything. So this level of fine-grained analysis is possible only with videos. But if you look at most of the other studies that have been done in the past, that look at disruptions and so on. They do in person. And there's a lot of advantages to that too, because you're embedded, you're in there, and you can ask questions of people if you need to. You can hear things, you can smell and feel things that you can't in a video. So you're a little away from all of that. So one of the challenges for us with tracking SFDs was we couldn't, the video audio call, even though we did record audio, it wasn't very high quality because there were so many other noises in the OR, so it was a little disturbed. So there's another category of SFDs which are related to communication, and that's a big problem in the ORs. We couldn't really track that because our audio quality wasn't good. So that kind of SFD is better tracked if you're in the OR. So there's just pros and cons. But we were able to spend some time in the OR, but not as much. So this gives us time and distance to be able to really go into it in a lot of depth and play back and do all of that. So again, I wouldn't say one is completely the way to go. I think you probably need to do both. Even if you do video observations, you probably want to spend some time in the OR and get situated and understand really what's going on with all your senses.
So speaking of that, there was another question. What does SFD stand for?
Surgical flow disruption. I should have defined it. So these are any kind of disruptions or task interruptions that happen during the course of a surgery. So we call it surgical flow disruptions. But you can measure flow disruptions in an ED or in other places. So these are events that interrupt or prevent a task from happening. So usually they may be pretty low level, that you tripped over something, you picked something up, but whatever task you were going to do, you were disrupted from that. You were trying to work with your fellow physician, but somebody came and interrupted you. So that would be a flow disruption. And these are linked to safety. They are linked to safety outcomes. They're linked to errors, and that is why we're studying that really.
Well, obviously this video-based observation of lots of surgeries and trying to code all of this is a time-consuming process. How many hours of video did you end up having to dig through?
Well,
enough to make you grimace.
No, I'm not the one who did a lot of the coding. I should ask my students.
Right.
They're still here. They haven't left. So I think it's not, I think they learned a lot too, because it gives a completely different appreciation for what surgery is and how people behave when you actually spend that much time coding. But I would say for every 1 hour of video, if you were tracking, say, a circulating nurse or something, you were probably spending 3 times or 4 times as much time coding that. So the coding takes a long time. And the same thing with the flow disruptions. We had a different person code the flow disruptions. So it is a very time-consuming thing because you often have to stop, code, then play back and make sure everything is correct, and then move on to the next thing in case you missed something. But for all the time they were coding the location and the broad tasks. Initially, we were going to even do subtasks like, environmental hazard, what kind of environmental hazard, and what object were they using or interacting with. And we quickly realized that that's just impossible. I mean, there was just too much and it would just take forever. And we felt this was a broad enough amount of information that we needed so that we could move beyond the fine-grained stuff.
Fantastic. And any advice for other people who want to take a similar approach?
Yeah, I mean, I think, I think it depends on the questions. If you're in the process of building a new OR and you're renovating an existing OR and you want to understand what their problems are, what are some issues that you need to address, obviously you don't want to just go with our prototype and say, hey, they did this, it's going to work. You want to understand what they are doing. In that case, doing this kind of a heavy-duty video-based research may be a bit too much for you because it would require hours of coding, the expertise, and all of that. If you have a research study, then that's fine. Otherwise, I would recommend you spend time in the OR, maybe use some of the protocols that we developed just in terms of even tracking very simply on paper, where are people going, where do you see obstructions, just on paper, having the OR plan with you, or tracking the number of SFDs. That can be done on paper. It may not be a heavy-duty study that you want to publish, but it will give you good situated information that then you can help, that can help you in the design process. So I think that depending on your focus, your approach might be different.
Seems really helpful. We have a question. How does daylight work with surgical procedures in terms of causing shadows, colors, renditions associated with procedures that the surgeons might not be used to from experience with other ORs, not having natural light, patient privacy, etc. In general, what makes daylight important in an OR?
That's a great question. I mean, that's something that we looked at pretty early on in the project, because it seemed like in all sorts of workplaces you have daylight, and operating rooms used to have daylight. I mean, if you look at any of the pictures of the old operating theaters, there's a big old window out there and there's people sitting around on the thing. So what happened along the way? So we looked at some of the precedents. We looked at examples from Europe where they're required to have daylight in the ORs, and so you have ORs with daylight, and they have many of the similar kind of surgeries. So, but I do understand the challenges with color rendition and being able to see the screens and glare and all of that. And I think having the light is beneficial, but you should be able to control it. So you should be able to black out as needed, because there may be times during the surgery where you cannot have the windows open, but you should have the options of putting the blinds up during turnaround time or during in-between surgeries, so that people who are there throughout the day, they come in usually at 6 a.m. in the morning and they leave at, say, 5 or whatever. So they spend the whole day without seeing any daylight, because the surgical suites often don't have daylight either. So there are ways of implementing that, and ORs have done that. But it can be a challenge, especially if doctors are not used to it and they have concerns about how it's going to impact their work. So you need to work with them and provide options for how the daylight is integrated. Some people have done it where you have indirect or borrowed light, where it's a small window on the top. At least you get a sense of daylight and how it's changing, even if it's not views. And others have lights out in the corridor, where at least if you step out of the OR, you can have some access to daylight. And at least with the two hospitals at NUSC, one is a new building, and they have the corridor with daylight, and it's pretty clear that people are much happier there. We didn't do a study to see if it's the daylight that made a difference, but anecdotally, they all said they love having the daylight. And the other one, they're all pretty grumpy. I mean, they're not as happy, let's say.
Well, having lived at different latitudes at different times, I can imagine, especially up north in the winter, just getting to see some sunlight during the day makes a big difference. I know you said that you obviously you worked in one healthcare organization and you've talked to people and not gotten any feedback that this is really outside of their experience. But we do have a question: are the observed circulating nurse processes typical for these procedures at this hospital and representative of similar procedures of other hospitals? Do you have a fair amount of confidence that this would be a useful set of lessons learned, even if not direct research applicable to other organizations?
No, absolutely. I think even though we looked at only one health system, I think the kind of task that the circulating nurse does in these surgeries is relatively similar across. They have certain tasks that they're supposed to do. They're supposed to maintain sterility. They're supposed to be the ones who are managing the information, who are keeping track of the surgical checklist, who are making sure that that all the supplies and things that are accounted for, they're the ones who will go out and get equipment or instruments if something is missing. So all of those things are very much similar, but different kinds of surgeries may require additional or different tasks. If it's an open heart surgery, there may be more people in the OR, and circulating nurse staff might change a little bit. Or if it's like we're working on a project, we're looking at C-section rooms. So there, the circulating nurse has many of the same tasks, but then you have additional team members. There's a pediatric team, and there's the mother team. So there are more people. So overall, the circulation may change depending on who comes into the picture. But in general, I think the tasks that the circulating nurse does are not incredibly different. Because we worked with several of the nurses, and they worked in other facilities as well. And we've presented this work to doctors and people from Greenville Health System, from other health systems, and no one kind of said, our nurses don't behave like this. So we think there may be no universal truth, but they're not completely unique either.
Fantastic. I got a question. Have you found any advantages to having, it says the CR, but I assume it's the circulating nurse, workstations being configured to be able to see the sterile field versus facing away from the sterile field? Or if CR means something I'm not aware of, you can answer it for CR.
No. I mean, I think that was something that was pretty well defined early on, that the circulating nurse needs to be able to see the sterile field all the time. In fact, that visual to the sterile field and to be able to maintain the sterility during all phases of the surgery was deemed very important. So even like where we placed the scrub sink, at one point we were going to place it a few feet away, and we received a lot of pushback from the clinical team saying that would mean that they would wash their hands and there would be a few feet where they wouldn't be able to keep an eye on what's happening inside the OR, and that was not acceptable. So they needed to be able to wash their hands and come right in. So having the circulating nurse being able to maintain that view of the sterile field is extremely important. So having the back to the sterile field would not work. And I have seen that in a couple of places. They seem to circumvent it by having a video feed that the circulating nurse can keep an eye on while the back is turned, though I don't know if that's ideal. But at any rate, even if the back is turned, they would need to have a visual to the sterile field, because that's their primary task, is to make sure everything's okay and to be able to see what's going on and to be able to help when needed.
Great. You mentioned earlier that, this was one part of much broader set of work that you're doing, and that you started with the circulating nurses and you're expanded, which relates to the next question is the circulating nurse the most important person in the room? Will surgeons and other people balk at the idea of designing an OR in order to make the circulating nurse most efficient? My limited experience with surgeons is they'll balk at nearly anything given the chance. Is this something where you've brought in other data from the other? I mean, you're on year 4 now of this project, I think, to bear on this as well?
That's a great question. I mean, for this particular analysis, we have this large database. So we have data on the behavior of each and every person in the OR. And we know we measured surgical flow disruptions for everybody. So the data that I presented here actually was just the SFDs that the circulating nurse was involved in. So the total number of SFDs is much larger, and it includes SFDs from the anesthesiologists that the surgeons were involved in and whoever. So we have all of that, but this particular paper just looked on the circulating nurse, and we did that because the circulating nurse is the most mobile member of the team. Everyone's equally important, in my opinion. So they may have contend that, but I think they all have a very critical role to play, and that's the key thing about the surgical team. Even though the surgeon may be doing the life-saving or the critical surgery, they cannot work on their own. It's a team effort. It's very much a team effort, and they all have to make sense of it. It's kind of like a sort of a very highly coordinated dance that they play. We looked at the circulating nurse primarily because they were moving around so much in the OR, and they are likely to be they're interacting a lot with the built environment around them, right? So they're interacting with the layout, with the things. So that's why we decided to start with that analysis. But we've done a bunch of papers since then. We haven't analyzed. Well, actually, one of our teams looked entirely at the anesthesiology workstation, and they tracked where these people were going, what they were doing, so that we could come up with the sort of the ideal anesthesia workstation layout to minimize people having to look away from the patient and so on. So this is just one analysis, and as I think I mentioned, it's way down there. We have looked at a bunch of other different pieces in the study. And so these are all our publications so far from this particular project in the last 3 years. And we have others that we're working on, including the Markov chain analysis that I mentioned and the anesthesia work. So we've been looking at all of these components. And it really is a systems approach. So even though this study talks about the CN, we are looking at everyone's behavior, the needs and adjacencies and so on for all the different team members to come up with the prototype design.
Fantastic. And this brings up another question that actually wasn't for you, but for us. You'll probably want to spend some time looking at all these titles. And yes, for those of you who have asked, the video of this presentation will be available on the 24th, starting on the 24th. So thank you for that question. And so here you have this great list of things that have already come out. You must have more that's still emerging because you have such an immensely large and rich data set. Could you just give us a little highlights reel of what else we should be looking for from your research group?
Sure. I mean, as I said, we want to look at sort of the anesthesia from that existing database, but we also have the proactive sort of modeling paper that I'm really excited about, because I think in our field we always deal with this question of how big is big, or should I do it this way or that way? And unless you can do a simulation, we can bring people through and get some feedback, but you don't have any objective way of tracking that. So I think this proactive modeling paper, the work that we've been doing with industrial engineers, is really exciting, because it gives us an objective way of comparing 3 different designs and saying, okay, is this one going to perform better or that one, with some objective metrics. So that is going to be great. As I mentioned, we have this prototype OR that we've built. We're going to do some simulations with a high fidelity patient simulator with the full surgical teams. So that will help us refine some of our ideas even more. And then all these concepts, a lot of what we've designed in this prototype OR is implemented at MUSC in their new surgical center, and that's going to come online in April, I think, next year. So the idea is for us to go back in, maybe before pre-occupancy, to help them transition into this new facility, help them figure out not just the design issues, but any other workflow issues that they may be facing, and then go in maybe 6 or 9 months after that to do a post-occupancy evaluation, where we go in and again do this video recording of several surgeries and collect this data about the flow disruptions, the workflow, and then compare. Did it make a difference? So that's really the joy of doing this 4-year project, which we can go through this whole process and really come to the end and do the post-occupancy as well. So that's kind of what's coming down the pike. And I should also mention, we are building a OR design toolkit, which will be an open source website, essentially, where all the stuff that we've learned through this grant will be made available. We're really focusing it around key evidence-based design goals and looking at what are the different kind of strategies with regard to the built environment, with regard to the tools, the people and processes that should be thought about together to help in these outcomes, such as reducing surface contamination or reducing workflow disruptions. So those would be the goals, and then you can think about strategies and case studies and so on. So it's going to be really cool, and hopefully we'll have it all together and it'll look great and be very easy to use and all of that by August of next year. So we'll see.
That's really exciting. Thanks for sharing that with us. We seem to have run through the questions, so we'll move on to the next slide and say thank you very much, Anjali, for this really interesting, exciting work and sharing it with us. This concludes our event. We'll leave the webinar open for another 30 minutes so you can download the EDAC and AIA-CEU forms. Thanks, everyone, for joining us, and have a great day.
Thanks, Alan. Thanks, Enterprise Design. Good talking to everyone. Bye.
Bye.